So let's go into how are bones forming, all right? The synthesis of bone. So we call this osteogenesis, the formation of bone. Got a few, this is probably, I think, the hardest material of the lecture portion of the skeletal system. Not too hard, but the hardest of it all. But I have a couple videos to help you along with this to show you. So that should emphasize a little bit more. All right, so osteogenesis, all right? Basically, it's new bone formation. And we can either do this two different ways. They can either start with mesenchyme, which is this membranous connective tissue. That's really the part that's going to be the origin of all the connective tissues. And this mesenchyme will immediately start making bone from where it is. Or this mesenchyme is going to make hyaline cartilage, and then it's going to make like a skeletal template from the hyaline cartilage. So it could go to either way. Does that make sense what I'm saying there? All right. You can either start making bone right from here and skip in cartilage, or it can make cartilage, and this hyaline cartilage is going to form this skeletal template to have the bone form from that. Okay. And this pattern is actually completed by the 8th week of gestation, after 8 weeks after fertilization. So we have two ways that we could do this. Something we call intramembranous ossification, and intramembranous means that it's coming from mesenchyme directly, and that's going to form flat and irregular bones. Or the mesenchyme can turn into hyaline cartilage, and then this hyaline cartilage, which is going to be a skeletal template, is then going to form the rest of the bones. Okay? Intramembranous ossification is coming from mesenchyme. Endochondral, chondral means cartilage, is from the hyaline cartilage. So membranous, mesenchyme, or endochondral with a C there, chondral cartilage, if you want to use that as a mnemonic. Okay? So this is what it looks like. All right? And the chondral bones forming, which is the majority of the bones forming, you can see in the arms. Okay? Intramembranous is going to be flat bones, which I explained are going to be the skull bones, is a good example of that. Okay? So let's talk about intramembranous ossification, and then I'll show you endochondral ossification, and then show you a quick little 6 or 7 minute video explaining this. So it's a little bit of animation. If you don't understand it now, by just having the words and my pictures, the animation will just fine-tune things for you. So intramembranous ossification is the way flat and irregular bones do their thing, and the clavicle. Although the clavicle is a long bone, this is your collarbone here, this is the only long bone that actually goes through intramembranous ossification. What happens first in this kind of ossification is mesenchyme becomes osteoblast, and it's going to make something called the ossification center. Osteoblasts are then going to deposit osteoid. And osteoid is going to be around them. As we expected, when I kind of showed you, osteoblasts are going to lay down the bulk of the bone, the osteoid. The osteoid is going to become calcified by adding in the calcium phosphate, or better known as hydroxyapatite. Okay? This is going to become woven bone. Woven bone is the same thing as spongy bone, except this is found in the fetal development. It's not found in the adult or the child, for that matter. Once the osteoblasts are surrounded by the matrix, they paint themselves in a little corner. Now they're in a lacuna, and they're now known as osteocytes. Meanwhile, the osteoclasts are going to go back into the bone matrix and start chomping away like little Pac-Men and creating the medullary cavity. Blood vessels will start forming in there and creating the bread bone marrow. Osteoblasts that are still not surrounded by the matrix that just laid down, they're going to be found underneath the periosteum, on the outer rings or the outer edges of the bone itself, just under the periosteum. And they're the ones that are going to lay down bone matrix and create the compact bone. The surfing mesenchyme becomes the periosteum. Whatever is left over, that's going to be outside of where the osteoblasts are. So here you have the osteoblasts in yellow over here, and they're going to start laying down the bone matrix, the osteoid. As they're laying down the bone matrix, this beige area over here, this is an osteoblast that has surrounded itself with matrix and now is sitting in a lacuna, and it's not an osteoblast anymore. It's now known as the osteocyte in the lacuna. Meanwhile, the osteoblasts are all around the outside. They're laying down the bone matrix, and this is getting wider and wider and wider. So this here, where my arms are going to be the periosteum. So this will be underneath the periosteum. Blood vessels will start going in here as the osteoclasts are going to start chewing away and allowing the blood vessels to enter there and forming the medullary cavity. So you're going to have this medullary cavity here. Here's your osteoblast on the outside. This is all the bone matrix itself. This will be our future periosteum. So we can see it over here. The trabeculae is over here. Spongy bone. You can see spongy bone happening here, and compact bone on either side. Okay? I'll show you a video of this. Don't worry, you'll get it. Then we have endochondral ossification. This is where we're going to lay down, the mesenchyme is going to make hyaline cartilage and create a template for the bone to say, hey, this is the way we want our bone to be formed. This is most of the bones going through this, with the exception of the ones that we just mentioned, flat bones and irregular bones and the clavicle. Okay? So most bones undergo this ossification. Hyaline cartilage is formed and creates a skeletal pattern, whatever it's going to be, a long bone, whatever it's going to be. Blood vessels and osteoblasts enter the perichondrium. You see, it's not the periosteum at this point. It's not there yet. Since it's made out of cartilage, we call it perichondrium. Again, chondro means cartilage. At this point, it's still cartilage. And it's surrounded by hyaline. This occurs by the 12th week of gestation. All right, 12 weeks after fertilization. Osteoblasts then change the perichondrium to periosteum. And the osteoblasts form what we call the bone collar, something like a ring around the shaft of the bone. The hyaline starts hypertrophying, start getting bigger and bigger, each one of those cells, okay? And it ruptures in the center of the bone. The contents of these cells, okay, of the ruptured chondrocytes, change the pH in the extracellular fluid. It increases, becomes more alkaline. So this alkaline extracellular fluid will then calcify the matrix, and that's when hydroxyapatite or calcium phosphate is formed. Osteoblasts then penetrate the disintegrating hyaline and replace it with spongy bone. And this forms what we call the primary ossification center. This is located in the diaphysis. We haven't done the epiphyses yet, the ends of the bones. We're just talking about the shaft of the bone itself. So you have the primary ossification happening over here. We're going to have this bone collar that's kind of going around the whole thing, not just on the two sides. You've got to think three-dimensionally. It's going to go out of the screen and into the screen. Okay? And that, all this blue stuff is cartilage that turns into bone as we get further along. Now the ossification continues from the center of the diaphysis, and now it goes towards the ends of the bones, the epiphyses. Osteoclasts, the Pac-Man, are going to start breaking down and resorbing the spongy bone to open up the medullary cavity in these areas. And as they do this, the blood vessels will start migrating into that medullary cavity. Cartilage in the epiphyseal places, epiphyses at the ends of the bones, they continue to grow to allow the bone to increase lengthwise. After birth, we now have secondary ossification centers. These are going to be located in the epiphyses, at the ends of the bones. The ossification is the same as diaphysis, except in the spongy bone, except where the ends are, the epiphyses, there's no compact bone there. It will always and remain spongy bone. Once complete, everything is replaced with bone, except two places remain hyaline cartilage throughout the rest of the person's life. The ends of the bones, because as I showed you before, you want one bone here and the other bone here, where they rub against each other, you better have cartilage over there, because bone to bone is going to cause a lot of pain. So there's going to be articular cartilage there that's made up of hyaline cartilage. The other place that you're going to find hyaline cartilage is in the epiphyseal plates, the place where there's going to be length growing of that bone until it fuses at about 20, 21 years old. So again, this is where we have it. This is where we're going to deteriorate this area, where osteoclasts are going to come in the center over here, get bigger. You're going to see blood vessels coming into here, forming the bone marrow there. You'll also see, so here's the blood vessels coming in, and you're going to see up here in the epiphyseal plates, it starts forming our secondary ossification center. But this area here is going to remain spongy bone, whereas there's compact bone all in here, not the center part, but all through the diaphysis you'll have compact bone all around there where the bone collar is. This remains spongy bone. The only two places that you're going to find cartilage remaining is going to be the ends of the bones where the articular cartilage is, and the place where we're going to have growth lengthwise occurring throughout the child and adolescent's life through the epiphyseal plates. Those two areas on either end are going to remain as hyaline cartilage, and they have their own reasons for those, as I just mentioned. So there it is in one picture form. All right, so again, you can see at the ends of the bones, it's all spongy bone. Over here, it's compact bone, but there is spongy bone just underneath the compact bone, and it's the perimeter of the medullary cavity.
Bone formation, also known as osteogenesis or ossification, is the process by which bone tissue replaces embryonic connective tissue to form the skeleton. From childhood to early adulthood, ossification lengthens and thickens bone. In addition, the process of ossification is used throughout life to remodel bones. There are two methods of prenatal bone formation. During intramembranous ossification, bone is generated on or within fibrous connective tissue membranes. As the process begins, mesenchymal cells differentiate into osteoblasts in regions called ossification centers. The osteoblasts secrete osteoid or uncalcified bone matrix. Over a few days, osteoblasts become osteocytes, and calcium and other mineral salts are laid down, hardening the matrix. The bone matrix develops thin columns of bone called trabeculae, which fuse to form spongy bone. blood and lymphatic vessels grow into the surfaces of the newly formed bone and develop red bone marrow. Outside of the bone, a dense layer of connective tissue called the periosteum forms. Most outer layers of spongy bone are eventually replaced by compact bone, but the center remains spongy. Intramembranous ossification also occurs with skull bones in childhood. At birth, skull bones are separated by fontanelles, or soft spots, and sutures, immovable joints made of fibrous tissue. Fontanelles in the fetal skull allow for easier passage through the birth canal and rapid brain development. Up until adolescence, the fontanelles slowly ossify into sutures, providing the brain with greater protection. Endochondral ossification, the replacement of cartilage by bone, occurs in most bones of the skeleton. The process begins when embryonic mesenchyme condenses, forming the cartilage model, the shape of the future bone. The model grows within the fetus. Lengthwise growth is attained via interstitial growth. Width is attained via appositional growth. A nutrient artery penetrates the perichondrium, increasing nutrient availability to the cells. Osteogenic cells are stimulated to differentiate into osteoblasts. These cells secrete matrix beneath the perichondrium that forms a thin shell of compact bone known as the bone collar. As the perichondrium begins to form bone, it is now called the periosteum. The bone collar reduces diffusion to the cartilage inside the model, depriving it of nutrients. Capillaries grow into the disintegrating cartilage, delivering osteoblasts. The new growth forms a primary ossification center, an area where bone tissue will replace most of the cartilage. Osteoblasts deposit bone matrix, building spongy bone trabeculae. The growing model is gradually remodeled. The cavity fills with capillaries and red bone marrow. Ossification proceeds, forming the main portion of a bone, known as the diaphysis. Around the time of birth, blood vessels enter the epiphyses, the ends of a bone, forming secondary ossification centers. Secondary ossification differs in that no medullary cavity forms, and ossification proceeds outward. As a result, the interior of the epiphysis remains spongy. Secondary ossification leaves a thin layer of hyaline cartilage covering the epiphyses. This is known as articular cartilage, and it reduces the friction and shock in bone joints. The change to the epiphysis also forms the epiphyseal plate, a layer of hyaline cartilage that enables the diaphysis to grow in length.
So bone growth occurs in the epiphyseal plates, the area we call the metaphysis. Bone grows lengthwise that way, similar to endochondral ossification, whereas hyaline cartilage, since that's what's there, we're going to have it divide through mitosis. Chondrocytes, that's the cells of hyaline cartilage. Chondrocytes are next to diaphysis. Chondrocytes there are going to grow. All right. Osteoblasts move in to form the bone, and the process keeps on occurring. So what happens again is that you're going to have, if this is, I think I showed you this before, this is going to be your epiphyseal plate. Now I'm making these chondrocytes bigger than what they are, but what will happen is one will go up like this through mitosis, and one will stay in this area over here. And then this one could go through mitosis, one will stay there and one will move up. Then this one could go this way and one will move up. Does that make sense? Mitosis. It's going to go lengthwise. And this happens until about 20, 21 years old, when it fuses, and no longer can it actually go through the mitosis that we're seeing, and we call it the epiphyseal line. It fuses. Okay? And again, bone growth is under the influence of with hormones. Growth hormones, sex hormones like estrogen and progesterone, or not progesterone, that's a pregnancy hormone. Estrogen and testosterone will do that. Thyroid has contribution to this also. Okay, so we can see that there's a lot more estrogen and testosterone happen in puberty, so you have that growth spurt that actually happens. Okay, so here they're trying to show you epiphyseal lines in long bones. All right, but keep in mind, we're thinking long bones like arms and legs, but they're also in the fingers. Each one of your fingers, which we'll talk about, these are called phalanges, they have ends to their long bones, so you're going to actually see epiphyseal lines in those areas also. Okay? Now, appositional growth. What I just showed you in bone growth, it's making the bone grow this way. But we got to talk about what makes the bone grow this way. Okay? And this goes on throughout our entire life. We call it appositional growth. We're going to start chewing away at the bone to get the calcium into the bloodstream, but then we got to put the calcium back into the bone. So it's going to be growing widthwise that way. So it increases the thickness and diameter of the bone, and it continues, like I said, throughout the entire life. This is due to muscle activity increasing and weight gain as we go along. It's also important when we deal with new mechanical stresses that you put on the bones. All right, you want to be carrying, like 20 bowling balls on your back, or let's say on your stomach, and you want to walk like a crab would walk, like this kind of thing. Well, your body's going to be dealing with new stresses at different angles, and it starts to need to grow in different ways. So what happens with oppositional growth is that osteoblasts are going to lay down the layers from the outside and moving inwards, and this makes the bone thicker. Whereas osteoclasts are going to dissolve, or a better word that we use is resorb the bone from the inner surface and goes out, and this widens the medullary cavity. All right, so you're going to have osteoblasts from the outside going in, and then you have the osteoclasts going from the inside going out, and they work together. Okay? You see osteoclasts going this way, osteoblasts going that way. So appositional growth, tearing a bone is good to produce new bone. You want that to happen, as you've seen new stresses that occur with your body. All right, it makes the bone stronger. So when does oppositional growth not occur? When there's no stress on the body. When does that happen? Well, whenever we're not weight-bearing, when there's not weight-bearing occurring on the bones. Things like bedridden people, right? They're just lying there. They're not doing anything. So it's important that they're doing weights in the bed, or you see exercise going on when they're in a coma, right? You got to get the stress on those bones. Otherwise, they're just not going to be doing it properly. Astronauts, as I mentioned before, there is no gravity up there, so I don't know much about astronaut life, but if you're up there for a month, they're going to put you in a gravitational room for, 3-4 hours a day, so that you have the stress that's on the bones, because when you come back after a month, you're going to have probably osteoporosis, because there wasn't enough stress on the bones.
Alright, so on this diagram of the two guys and the bone, the guy on the outside, building up, that's Bob the Builder. He's building new bone. He takes his bricks made out of calcium from the blood. So when Bob needs to build up the outer layers of bone, he takes calcium from the blood and puts it into the bone. The guy on the inside is Claude the carver. He is an osteoclast. Claude is the osteoclast. Claude was the only CL name I could think of. So Claude is the osteoclast. He is carving away the interior of the bone, and as he's carving away, if you can imagine little chips of bone coming out, now this is all on a cellular level, but if you can imagine little chips of bone coming out, what he's freeing up and what he's releasing is calcium, and that calcium goes back into the bloodstream. So Bob and Claude kind of work together to maintain this balance of calcium in the bone and calcium in the blood. Calcium is hugely important, not just for bones. Bones are kind of secondary storage areas for calcium. Calcium is really important in muscle contraction and nerve conduction and all kinds of things in the body. We always think of calcium for strong bones and teeth. Bones and teeth are kind of the storage area of calcium because it's needed in so many other things in the body. So these two kind of work together. Why can't we just have Bob building up bone all the time? It would be too heavy, right? It would be so heavy that we wouldn't be able to move our skeletons. And then Claude, if Claude was left with nobody working with him, what would happen? There wouldn't be enough calcium in the bones, and we would end up with what? Osteoporosis. We wouldn't have enough calcium in the bones. If we have a calcium deficiency, then Bob runs out of bricks. Bob has nothing to take from the blood and put into the bones. The calcium's going to go where it's needed more, like to the muscles and the heart, before it goes into the bone. So Bob's like way down on the food chain as far as calcium goes. So Bob's going to be the last one to get the calcium. But Claude, he's still working away, and you end up with bones that aren't very dense, that don't have a lot of calcium in them, and then the patient's at risk for what? Fractures, right? Very good, fractures. So the idea here is that the osteoblasts build new bones, osteoclasts break down the bones. If the blood calcium level is very low, who do you think gets overtime? Bob or Claude? Claude, why? Exactly, because he's releasing calcium from the bone and putting it back into the blood. There's two hormones that work together to maintain our calcium balance. One puts Claude on overtime, the other one puts Bob on overtime. All right? So if our calcium levels in the blood are very high, then who goes to work? Bob. Bob takes the blood calcium and shoves it into the bone. Okay? All right, very good.
There's two types of dwarfisms. There's one, the most common, MC's most common form of dwarfism is something called achondroplasia. All right, about 70% of dwarfs will have this. This is where the long bones stop growing because there's a premature fusion of the epiphyseal plates. So we're looking at mostly long bones over here. The head and torso appear as an adult form, but the arms, the legs, the toes, the fingers, they become short and stubby, okay? So that's a failure of cartilage growth to occur in the epiphyseal plate. That's the more common one. I'm going to show you pictures of this. But then we also have something called pituitary dwarfism. When we get into endocrinology and AP2, we'll go more into this also. But this is a lack of growth hormone. Growth hormone goes all over your cells. The heart, the lungs, the kidneys, the arms, the legs, the head. So if you have a lack of growth hormone, then you're all in proportion. You just happen to be a little person, so to say. You're all in proportion, though. The arms go with the size of the head. In this case over here, the head and torso are out of proportion with the arms and legs. So let me show you what achondroplasia is. Okay? Achondroplasia, notice the head of her is the same as the normal adult. Even the torso is the same size. But when we deal with the long bones, they are not the same size. And this is what Peter Dinklage, or he's from that Game Wars, what is that called? Game of Thrones, yeah. But you see his fingers, they're short and stubby. Okay? Not being mean about it, I'm just describing it. But look at his head and look at his torso. It's the same size as an adult. It's just his arms and legs are out of proportion. So that's achondroplasia. That is the more common form of dwarfism compared to pituitary dwarfism. Pituitary dwarfism is that their head is in proportion with the arms and legs. It just looks like a little person. You might want to put him on your fireplace mantle and see how cute he is and stuff. But he's probably like 55 years old. Okay? He's up there in age. He's not, what I'm saying, he's not a baby, you know. But he's in proportion with his body. So that's how you can tell. That's why I look at people. I have an idea of what people have by just looking at them. I can't help them. I don't go up to them and say, I know you have, you know. But, I mean, you know what I'm saying. If you understand, that's the whole thing about anatomy and physiology, let alone later on with pathophysiology. You get to learn about, you know, it's a manual about yourself and why is it that some people have diseases or conditions and other people don't. You get to learn about that. Well, let me do fractures and bone repair with you since we're on the subject of osteoclasts a little bit. And then we'll talk about some abnormal stuff and then we'll be done with bones. So fractures and bone repair. This is what doctors usually use for our symbol for fracture, this tic-tac-toe board. You young ones over here call it a hashtag. I don't even know what a hashtag is. All right, but we see that, especially for radiography, doctor might say rule out hashtag. He's not trying to, you know, put you on Instagram or anything like that, but that's what that is. All right. So it's any kind of crack or break that's due to some kind of extreme mechanical stress. Most will heal, you know, we'll put a cast around it, and most will heal well, as long as you have the blood supply going over there. Now, there's some fractures, which I don't want to go into, but there's certain fractures that might have only one blood supply going to that bone. Like a scaphoid is a good example, which is part of your carpal bones. If you kink that blood vessel, then that's not going to get blood supply to that scaphoid area if that was what was cracked or fractured. So it has to be put in a certain kind of formation in a cast so that the blood supply won't be compromised. So that's why it's always important when you're putting casts on that there's certain ways you got to put them on. All right. So as long as the blood vessels are not going to be compromised, they will heal quite well. Okay. Cartilage, on the other hand, not good. All right, there's no blood supply there. All right, so there's two major categories of fractures. It either breaks the skin or it doesn't break the skin. If it doesn't break the skin, then we call it a closed or simple fracture. If it does break the skin, then we call it an open or a compound fracture. Those are more deadly. A lot more blood loss occurs there, obviously, and also you just punctured the skin, and now you've got the medullary cavity open, which is where blood cells are. So now you have bacteria that's on the skin that's able to go in. You just created a window so that bacteria can come inside the body. So those are what we're concerned about with open or compound fractures. So we're just showing you closed fractures here, open fractures over here, breaking the skin. Now, there's a lot of different forms of fractures that we have, a lot of different types. A transverse fracture is just, if this is the bone over here, that's a clean cut, straight back, straight down. A transverse, okay? Then we could also have a spiral. That's kind of difficult for me to draw like this, but think of it as a fracture that kind of goes this way and then around on the other side, fracture like that. You know, it's like a twisting kind of thing. We're just going to go around there. Then we have a displaced fracture, and a displaced fracture, this is that, maybe that way. Now, it might, this displaced fracture, it's not to put it back the way it was. This might break the skin, it might not. So we could have a closed or a compound displaced fracture, okay? So here's a spiral one. You see it over here. It's like cracked over here and then going this way. I'll show you another picture in a little bit. Okay. A compression fracture we see with older women going past menopause is a good example of this, although that's not the only time we'll see it. The vertebrae, since there's a lot of osteoporosis that happens in the elderly, what happens is they become more like styrofoam, the vertebra. So as the pressure goes on there, it kind of crushes the vertebrae. It compresses the vertebrae. And that's the reason why grandma gets smaller. All right, she gets shorter because of these compression fractures in the vertebrae. Okay. Green stick fracture, we usually see it in children, and the best way I can explain it, you ever take like a branch from a small twig that came off of a tree, so it's really fresh, and you break it, but it's still attached by the bark, all right? It's kind of doing this thing. See how it's still attached to one side over there? All right? So that's what, I mean, you should see it, I'm not too sure why, but we see it more common in children, a green stick fracture. Not sure why they even call it green stick, but that's what they do. But it's where the one side is still attached, but it's kind of broken off. And it's basically, take a twig and break it, it's still attached on one side, it's a fresh twig, that's what that is. A comminuted fracture, it's in pieces, it's shattered. Okay, there's pieces all in there. All right, that's the one that's going to need a lot of screws and plates and things like that. Okay, so here's a green stick fracture, kind of like what I drew for you. You see over here, it's attached here, but you can see the break over here. You see that? Okay. That's a comminuted fracture. It's all in pieces. Okay. We have the epiphyseal fracture. Those are pretty bad. Okay, not that these aren't, but this is pretty bad, especially if it's in a young one, a child or an adolescent. This is where we're having a fracture that actually goes through the epiphyseal plate also, so it extends into there. So now it's going to interfere with the growth lengthwise of that bone. It might not occur. So now it happens in one leg bone, but not in the other one. So now one leg bone is going to grow faster than the other one, and they're going to be like this. And that can actually cause like scoliosis, the curvature of the back. So this is one we take seriously. And what they end up doing with this, actually when I went for physical therapy for my own knee, I talked with I guess he was about like 14, 15 years old, and he had one of these. And I'll show you a sort of picture afterwards. But there's this metal ring, a couple metal rings that go around the leg itself, and there's pins that go from the ring into, well, here, I'll just show you in a way. This is a very schematic view of this. Here's the epiphyseal plate over here. So technically, this is going to go outside the bone, so outside the leg actually, you have this kind of ring that kind of goes around here, and there's going to be a pin here and a pin over here. Basically a pin here and a pin here. And then there's a little, I hate to use this word, but that's what he called it, a crank. And every 2 or 3 days, the doctor has to turn this crank, and it makes this go that way and this way for about 1 millimeter every 3 days. I don't know exact measurements, but it's that. And the kid told me it's the most painful thing he's ever heard or ever felt, because it's that you're pulling the bone apart to create the actual bone to grow. So they got to do this. Right? So that's an epiphyseal fracture. Not so worrisome in, let's say, an adult, but during the child or adolescent, you got to be pretty aggressive with the treatment on this one. Okay. A Potts fracture, there's 2 leg bones that are in our shin area, something called the tibia and fibula. If both of those get fractured at the distal end, we call it a Potts fracture. We also have a Colles fracture, and this is where we have 2 bones in our forearm. And if the radius at the distal end breaks in a certain way, we call it a Colles fracture. You could look at the hand and the wrist, and you could see if it's a Colles fracture or not. The history will tell you a little bit. It's usually, here's a typical case. A woman, it's in the winter, and she goes on ice, and she slips and falls, and she extends her arm to try and break her fall, so that she'll land on her arm. And what happens is, when she lands on the ice, it kind of pushes this, and now you just fractured the wrist. They have like this dinner fork deformity. What's happening here, a Colles fracture is where the radius fractures here. There's another one called a Smith's fracture. Don't worry about that one. But here, it kind of fractures here, and it creates this dinner fork. If you look at the side of a fork, it has a, you know what I'm saying? And you could look at the hand, and you could almost see that's a Colles fracture. Does that make sense? This has to be positioned in a certain way in a cast so that it heals properly. But you could look at this, and he says, oh yeah, I feel like I can look at this and say, I know what kind of fracture that is. Okay? It's just this classic dinner fork. Do you know what I'm talking about with dinner fork? Not 4 prongs, but the side view of it, right? All right, so that's a dinner fork deformity. All right, and these are just different forms of the different types that we kind of mentioned on the fractures. Okay? And there's what they look like X-rays. Okay? So how does bone repair itself when there's a fracture that occurs? Okay? So here's some steps that occur. Make it very brief for you guys. All right? First off, when the fracture occurs, it forms a hematoma there. Okay? A hematoma is a collection of blood. All right? Kind of like a bruise. So you're going to have this fracture that happens, and you're going to have this fracture hematoma forming over here. Okay? Then you're going to have something called an internal and external callus. This is basically where the points of the spongy bone start growing, and it starts fusing with the other side. That happens at the spongy bone, but then we're going to have it more on the outer ends where the compact bone is going to start forming. So we have what we call an internal and external callus, where they start fusing with each other. Then the calluses will replace, and dead bone gets removed. So spongy bone unites with the broken ends, cartilage and external callus replaced with bone. And this all takes place within about 6 to 8 weeks. So you fracture a bone, it does take about 8 weeks for that to occur. The remodeling is where the osteoclasts start coming in. So in other words, this is where all fusion, after the hematoma happens here, you start having fusion where this green stuff is going to occur. So you have the internal, external calluses forming, and then the osteoclasts start coming in and start molding this to what it should look like. It starts chomping away so that the final bone will have just a slight little bend there, not too much. I mean, you could look at someone's x-rays and you have an idea where the fractures were in their lifetime. Alright, so hematoma happens here. It's kind of showing you where the internal callus is formed. The external callus is going to happen out here. And then soon enough, the osteoclasts start coming in here. This way you got a little, little bump over here. Osteoclasts will form in there. So you can see where the break is. You see a little bump over here. Okay? This isn't fully developed. You would actually see osteoclasts chomping away at that a little bit more. Okay?